Good morning. My name is Jay Singh, and welcome to our next installment of Virtual Journal Club with SHVI. This morning I have with me Dr. Noreen Kelly, one of our advanced structural imaging specialists and general cardiologist. And this morning we'll be discussing a topic that's very common in all of our clinics, which is secondary prevention, cholesterol management. The discussion will be based off of some of the landmark articles that have been included in the most recent updated guidelines from 2018. And I just wanted to start with, there has been some confusion with cholesterol management, the concept of moving away from LDL targets toward LDL thresholds. And I just wanted to start this morning by welcoming you and asking you, why is there so much confusion and what is the relevance for us in 2019?
Thank you so much for having me. So you're right. In fact, the new 2018 guidelines have said we need to start rechecking LDL in our patients, especially those patients who we're managing for secondary prevention of atherosclerotic cardiovascular disease. Because in fact, among all the studies we'll talk about today, what we found is that the lower the LDL, the better. We help them prevent subsequent strokes, myocardial infarctions, needing repeat PCIs if we get their LDL lower. And in fact, if we don't check it, a large percentage of our patients are actually coming off their medications and their LDL is rising above targets. Additionally, we found that there's a good percentage of our patients who are not getting their LDL below 70, even when they're on the right medications. And now we have new medications, the PCSk9 inhibitors, which can help us lower their LDL even further and help ultimately prevent some subsequent events, as we'll talk about in these trials.
Sure. And so this is an exciting development, the PCSK9 inhibitors. Can you tell us a little bit of how they work?
Yeah, so PCSK9 is an enzyme in the body that helps degrade LDL receptors, thereby increasing circulating LDL. And so what these inhibitors do is basically they inhibit that enzyme, you have more LDL receptors, and thereby less circulating LDL.
And I think the main trial for us of relevance today is the Fourier trial, which looks at stable secondary prevention in atherosclerotic cardiovascular disease risk patients. Tell us a little bit about the design and sort of what was being investigated.
Yeah. So this is one of the first trials to come out that looked at the clinical effectiveness of PCSK9 inhibitors. And in specific, they were looking at evolocumab. And it's a landmark trial because it's actually our largest trial. So over 27,000 patients. They took patients who had atherosclerotic cardiovascular disease, and they defined that as having an MI, stroke, or symptomatic peripheral arterial disease, and they actually looked at a pretty high-risk population. So you had to have one of those, but also some other risk factors. So an MI within the past 6 months, diabetes, tobacco use, things like that, age greater than 65, or two kind of minor criteria. So metabolic syndrome, low HDL, high sensitivity CRP. And all of these patients were on a high-intensity statin or their maximally tolerated statin and had an LDL greater than 70. And so they wanted to look at what was the clinical effectiveness. And so they followed patients for about 2.2 years on average. Their primary outcome was myocardial infarction, cardiovascular death, stroke, unstable angina requiring hospitalization, or revascularization, with a secondary endpoint of myocardial infarction, stroke, or CV death. I think I want to stop and tell you who actually ended up in the trial when we were looking at those patients. So, and for many of the studies we'll talk about today, over 75% of the patients ended up being males. The majority were white. Their average age was in the early 60s. About 70% were on high-intensity statin. There was a median LDL level of about 92. And actually, most of the patients came from Europe just based on where we were enrolling them. So when they actually allowed patients to choose whether they wanted the twice-a-month dosing or the once-a-month dosing, and patients were randomized in a one-to-one fashion, so randomized, double-blind, placebo-controlled trial. What they found was that at 2.2 years with evolocumab, the LDL had decreased by about 59%. So the median LDL in that population was 30, compared to the placebo where the LDL kind of had stayed the same. In terms of the primary endpoint, it occurred in about 11% of the patients who were on the placebo and about 9.8% of the patients who were on evolocumab. And if you looked at the secondary endpoint, it occurred in about 5.9% of the patients on evolocumab and 7.4% of the patients on placebo. So in both populations, about was a 1.5% absolute risk reduction. And so The authors report about a number needed to treat with that outcome of about 74 to prevent the secondary outcome at 2.2 years, excuse me. So one of the things to note, Jay, is that there was no mortality benefit. So when they kind of went through a hierarchical statistical analysis, there was no effect on mortality in the study.
And now we know that dropping LDL, there's always a lag time even in our previous trials and everything. Do you think the duration of the study had something to do with that, both in benefit but also in safety signal as well?
Yeah, so the major safety, they found no statistical difference in safety with the exception of injection site reactions, which is not necessarily to be unexpected, but it did not result in a significant discontinuation of the medication. They found no difference in incidence of diabetes, neurocognitive deficits, cataracts, things like that. Although I think you highlight a really important concern is that we expect those things to kind of develop after years and years of using the medications, and I don't think 2.2 years is really enough to kind of see that difference.
I think one of the things that impressed me most was both of these arms were pretty well controlled. I think I wish most of my clinic patients can get to that level of LDL to start with, but we still saw benefit and reduction in LDL. This patient population, you said it's higher risk. Would you consider these more stable patients? And what was the average time from their most recent MI event that were included in this trial?
Yes, so absolutely. So this is definitely a more stable population. So the average time between starting the trial to their previous event, whether that be their PAD or MI, was 3.3 years. So we're definitely looking at a patient population that's kind of further out from their inciting event.
And now, sort of the comparative arm that we wanted to sort of highlight that was also included in the guidelines was the higher risk population. So the recent MI patients, this was included in the Odyssey trial, another large population with a little bit longer duration. But do you mind highlighting that trial as well for comparison?
Absolutely. Yeah, so one of the things I actually stop and mention is that both in Odyssey outcomes and in the Fourier trial, if you had a myocardial infarction within the first month, you were excluded from the trial. And so although Odyssey is looking at more recent acute coronary syndromes, we're still only looking at 1 to 12 months following the event. So we're not talking immediately after the events. So this study was a little bit smaller, about 18,000 patients. They followed them for an average of about 3 years. The primary events they were looking at were cardiovascular death, stroke, myocardial infarction, and unstable angina requiring hospitalization. And so again, in order to qualify, you had to have an ACS event within 1 to 12 months, and that actually could be anything from unstable angina through full myocardial infarction. Most of the patients in the study actually had a myocardial infarction, so the smaller percentage was the unstable angina group. You had to be on a high-intensity statin or maximally tolerated statin, and again, have that LDL greater than 70. In both studies, I should mention the age cutoff was 40. So you had to at least be 40 or older. Fourier had an age limit of about 85, whereas Odyssey outcomes did not have an age limit. They excluded similar patients to Fourier in that you couldn't have significant LFT elevations, CK elevations, CKD, congestive heart failure, things like that. They were all excluded from those trials. So in terms of the primary event, what they found is actually very similar numbers to Fourier, and I think that's really important that we're getting consistent results with both of these medications. So again, they found about 11.1% of the patients on the placebo met the primary outcome at about 3 years versus 9.5% on the patients who were on alirocumab. So again, we're looking at about a 1.5 absolute risk reduction. If you extrapolate that over the 4 years, you're looking at a number needed to treat of about 50 patients. Again, there was no mortality benefit, but in some post hoc analysis that were really just hypothesis generating because they didn't meet the statistical criteria to analyze it, there was a mortality benefit with alirocumab if it was limited to patients who had an LDL greater than 100. And I think that's going to become really important when we talk about how do we use this in our current day practice, that kind of hypothesis generating data. And when you look at that patient population, the ones who had the LDL greater than 100, and if you look at them over 4 years, you're looking at a number needed to treat of about 16. So significantly better than what we've seen in the other trial, the other patient populations. Safety, again, was pretty similar. So again, higher injection site reactions, but nothing else in terms of cataracts, diabetes, neurocognitive deficits. But again, I want to reemphasize, we have about 20 years of data on statins and their long-term safety, and we're really looking at about only 4 years of data on PCSK9 inhibitors. And I think a lot of us believe that with low LDL, those effects may be seen down the line. The other thing I want to mention, which was interesting in the Odyssey trial with how they managed it with alirocumab, was that they actually titrated the dose. So they were taking people and really trying to target an LDL of 25 to 50, specifically avoiding the really low LDLs. And in fact, when the LDL got below 15, they switched the patient to placebo. And so what you see when you look at the reduction in LDL in that trial is it went from about 92 or 93, similar to Fourier, but only down to about 50. And that was actually designed by study design because they didn't want the LDL to go too low. And so that's actually another important thing. But even with that kind of titration and not as significant LDL reduction as Fourier, we're seeing very similar clinical benefits. And that, the benefit that we're seeing when you can get it to LDL of 50 becomes irrelevant when we talk about what they saw in the Improve It trial as well.
Sure. So I think you're bringing up, these were two populations that were with excellent secondary prevention control. In that backdrop, while those patients were being recruited, we sort of were bringing the concept of non-statin-based therapy to a population. And as you mentioned, the Improve It trial, we're talking now about ezetimibe, sort of adding on another more now generic and more cost-effective medicine in a trial, again, looking at a secondary prevention population. I think it is important to highlight that as well in context of these newer drugs.
Yes. So one of the major critiques and limitations of both Fourier, Odyssey, and the PCSk9 inhibitor studies to date is that patients weren't on ezetimibe. And it was because they were all kind of enrolling at around roughly the same time, and so we didn't have data to know what to do. So Improve It is a study that looked at ezetimibe. And what they did was, and there's some limitations to this study, as we'll talk about in a moment, but they also took about 18,000 patients. They enrolled them within 10 days of ACS and put them on simvastatin 40 plus or minus ezetimibe. And the major critique of this study is that patients weren't on a high-intensity statin. And as our guidelines say, they should be on a high-intensity statin if tolerated. The reason they also talk about why they didn't do that is they really wanted to get the LDL below 70. And so they wanted to make sure that the patients were close enough to an LDL of 70 to achieve that target when they added ezetimibe. And so what they found is that this was a long study, almost 6 years, 6 to 7 years of follow-up. And they looked at very similar outcomes as Fourier, so CV death, myocardial infarction, stroke, unstable angina requiring hospitalization, or revascularization. And what they found is that it occurred in about 32.7% of the patients on ezetimibe versus 34.7%, of the patients who were just on simvastatin. So again, about a 2% absolute risk reduction. I will note, so the starting LDL was about 90 and it got down to about 50. So we ended up actually at a very similar target that we see in Odyssey outcomes with the same absolute risk reduction. I think why there are so many more events in Improve It as compared to the other trial is the longer duration of follow-up. And almost 42% of patients had discontinued medications by the time the trial was complete, which I think is pretty consistent actually with what we see in clinical practice, that it's just hard for patients to maintain compliance with medications over the longer term.
And I think what you highlight is sort of our role as we sort of frequently follow these patients to keep re-emphasized and to keep checking adherence. One of the things that's interesting, whether you take the brand new PCSK9 therapies on stable ASCVD or more recent ASCVD, whether they're statin tolerant or statin naive, like in the Odyssey trial, and you add on ezetimibe, despite our follow-ups, whether it be 2 years to 5 years, we're still not seeing in clinical trial data that CV mortality thing that drives a lot of our value when we talk about these interventions. Can you speak a little bit to that and what your thoughts are?
Yeah, absolutely. I think it's been really hard for these studies to show mortality benefit, because they were taking patients who were already on pretty good goal-directed medical therapy. And I'm not talking just on statins. Most of the patients were on the aspirin, Plavix, beta blockers, ACE inhibitors, all of those things which already we know significantly decrease mortality. And so I think it's really hard when you're starting with a really well-controlled patient, well-managed patient population to show that additional mortality benefit. Plus, as we had talked about earlier, the event rates, especially if you look at Fourier and Odyssey, were so low because of that. So again, to show any sort of incremental difference is really challenging.
And I think it speaks to the starting population already having pretty well-controlled cholesterols. The guidelines in 2018 also, for the first time that I've seen in any of our medicines, started introducing the concept of value and started looking at, as these new drugs are coming to the market, how do we look at the value that they add, as they usually are sort of connected with higher costs as well. Can you
Yes.
sort of highlight how they approach that and how we should think about that as well?
Yeah, so there's been a number of studies that have looked at this. And the main way people kind of like to interpret this is incremental cost effectiveness, quality adjusted life year. And basically, as a society, we've kind of set thresholds. So we say if something is less than $50,000 for a quality adjusted life year, that's considered a good value. If it's greater than $150,000, it's considered low value. And what that means is over the lifetime of treating patients, our spending is going to exceed our cost savings from that medication. And so the guidelines looked at mid-2018 pricing for PCSK9 inhibitors and all the studies that had been done, and no studies had shown good value at the price they were at, and almost all showed low value. And so we've actually have some new information, though, where evolocumab has cut their price by about 60%, so it's down to about $6,000 per year. And actually in JAMA Cardiology just a few weeks ago, there was a new cost-effectiveness analysis that looked at the cost-effectiveness, the incremental cost-effectiveness quality-adjusted life year at this new price. And they found that if you had, for patients that had risk of about 6.9 events per 100 patient life years, it was actually a good quality, good value medication. And so the major problem we have is who are those patients? Who are the patients whose risk is 6.9% or higher on a given year? That's what we still struggle with to identify those patients. Additionally, there's been some other studies that have suggested if we really take patients whose LDL is greater than 100, that may also be a patient population for whom this medication at this new price is ultimately going to be cost effective. And there's kind of more to be determined on that front. I will say, I think one of the major gaps in our research right now, and in terms of being able to figure out who to use these medications in and the overall cost effectiveness, is that we don't have any studies where patients were on high intensity or maximally tolerated statins, ezetimibe, and then got the PCSK9 inhibitors. We're really missing that. And that's a big piece of data we're missing, because right now our guidelines talk about it, and we should talk about this in a little bit, that you go to high intensity statin, then you go to ezetimibe, and then go to PCSK9 inhibitors. And well, that's what our guidelines tell us. That's a data-free zone right now.
Sure. So I think one of the takeaways for me is I can do a much better job of honing in on those cholesterols and making sure that I'm monitoring both for treatment response and also for adherence. And I think the LDL 100 is a good threshold. Again, we don't talk about targets anymore because, as you said, there really hasn't been a J-curve with this. It seems like how low can you go? We can keep going lower.
Yeah.
I guess the long-term safety is still to be determined, but I think it sort of highlights the sort of day-to-day practical components of this. And also, I see now how the guidelines themselves have incorporated these three trials. Yeah. If I were to approach you with a patient who's had an MI, say, about a year and a half ago, they come into your clinic, it's a busy clinic, they're not taking their statin that they were prescribed, their LDL is 130. How would you sort of approach that patient?
Let me stop and probably talk about the 2018 guidelines, and specific the patient population we're talking about, and then we can talk about how we'd approach that patient. So the guidelines did something new this year. So they took patients who just had atherosclerotic cardiovascular disease. That means you've ever had a stroke, MI, had a stent, you have an aortic aneurysm, you have peripheral arterial disease. And they said those patients should be on a high-intensity statin or moderate-intensity statin, and their LDL should be less than 50%. And you're right, they don't give a lower threshold. They actually differentiated a different population, which is the very high risk. And I want to highlight this because actually almost all the patients we're seeing in our office are these very high-risk patients. So these are the patients who've had MI, symptomatic PAD, stroke, or have had an ACS in the past 12 months, but then also have some other risk factor. That risk factor could be that you have more than one of those events that I just talked about, that you're over the age of 65, that you have high blood pressure, diabetes, you smoke, you have CKD, you have CHF, pretty much all the patients we're seeing. And they said that you really should be targeting an LDL less than 70, but there's really no lower threshold, as you talked about. And the kind of progression is high intensity, maximally tolerated statin, then ezetimibe, and if your LDL is greater than 70, you can consider PCSK9 inhibitors, with the knowledge that we're not sure the cost effectiveness. Although, again, at these new prices, and potentially if we move the LDL up to 100, we'll have a good incremental quality-adjusted life year benefit. So for that patient, the number one thing they have to do, they're that high-risk patient, they've had an MI within the last 6 months, they've got to get back on their statin, and they've got to be compliant with it. One of the things we hear a lot, Jay, is I don't tolerate it, my muscles ache, things like that. And what we found is that, yes, there can be that, especially if you start right off with a high-intensity statin. But there's kind of this start low, go slow approach. So start with the atorvastatin 5, every other day dosing for a few weeks. Let the patient get adjusted to that. Then increase to 10 milligrams every other day. Then increase to daily. And unfortunately, we don't have any defined approaches about how to do that. But the concept is if you start low, go slow, you'll be able to get most patients on the medications. If they can't, once you've gotten them on their maximally tolerated dose, then start them on ezetimibe. The guidelines tell us it used to be, you're on a high-intensity statin, we never look again, and that's really fallen out of favor in the new guidelines. So after every dose adjustment, 4 to 12 weeks after dose adjustment, we need to be rechecking LDL. And then at least every 3 to 12 months in our patients on stable dosing to ensure that they're compliant. Because if we look at data like in Improve It, if we let them go 7 years, 42% of them are going to be off their medications, and we're going to have missed an opportunity for ongoing effective secondary prevention.
And I think that's an excellent point. I think at the end of the day, this is something that's relevant to all of us every day we're in clinic. And I think the new guidelines sort of help us where the confusion before was on do we check LDLs, do we not? I think we have very strong evidence that
yes.
LDL targets are important, both for morbidity and I think ultimately mortality benefit
yes.
as well. So I want to thank you for joining us this
yes.
morning. This was an excellent discussion, and I learned a lot as well. I think for us as going forward, I think the key takeaways for me were we are defining whether you're stable atherosclerotic cardiovascular disease or high risk. And I think most of our patients, as you mentioned, greater than 65, other comorbidities that need to be controlled, and multiple vascular beds affected, peripheral arterial disease, stroke, and multiple MIs or recent MI. I think they fall under that high risk category, and we need to be more aggressive. And now we have new tools that are in our sort of arsenal, starting with more cost-effective versions like ezetimibe, pushing the statin on individuals, and also the new PCSk9 inhibitors as well. So thank you all for joining us this morning, and stay tuned for our next virtual journal club.